wonderful Friday. I know all of you are working very hard for the COVID-19 pandemic and the response, so I appreciate all of your time and joining us today for the COVID-19 response coordination call. And this is our second round of digital technology themed discussion. My name is Lisa Hilmi. I'm the Executive Director of Core Group, and I am a nurse. So I salute all the frontline health workers that are out there making a difference, the doctors, nurses, and community health workers. Since February 6th, Core Group has been leading these calls weekly, and we've varied the theme, changing it to the relevance of what we're hearing at the country level and global level as what the needs are. It is an unprecedented time right now with over 1 million COVID-19 cases as of yesterday. They require collaboration and coordination, and that is the purpose of these calls. Additionally, we like this to be an opportunity for networking. In the chat box, you can put your name, you can put the organization and where you're located geographically. And many people are sharing their questions and answers, as well as some of their websites or things that we might be talking about today. Afterwards, since this is the second round, we have questions from last week and this week, and we have your email addresses, so we'll be able to send, if there's questions and answers that don't get addressed today, we'll send those to you via email. And we encourage you to join us weekly. Next week, we'll be looking at gender integration in the COVID response, and what are some of the gender issues that people, both women and men, are facing during this pandemic. Core Group conducted a rapid needs assessment several weeks ago, and one of the things that we did find is that at the country level, ministries as well as NGOs and CSOs were requesting more information on health education for informal workers and priority areas that really needed guidance for training or other resources. That included risk communication and community engagement, whether it be youth engagement, messaging, accessible technical information and clinical information, mitigating misinformation, as well as digital communication. And through that, it might be social media, webinars on the various education resources I mentioned before, looking at resource databases, dashboards, or looking at contact tracing, surveillance, how do you use DHIS2. So there's quite a lot of information and things that are already ongoing, and many countries have learned from previous outbreaks. It's my pleasure right now to turn the mic over to Magnus Conteh, who is the Executive Director of the Community Health Academy, good friend on the Board of Directors of Core Group, and also a nurse. So Magnus, over to you, who will be our wonderful moderator today. And Magnus, you'll have to unmute yourself. Magnus? Magnus, if you can unmute yourself.
I'm trying.
Okay, we can hear you now, but there's an echo.
Okay. My apologies. Can you hear me?
Yes, we can hear you without the echo. Thank you, Magnus.
Thank you. The power of technology always disappointing us just when we are doing this type of presentations. So good morning, good afternoon, and good evening wherever you are calling from today. You're most welcome to this call. And as Lisa already mentioned, I hope that you and your loved ones are well and keeping safe wherever you are. Welcome to the 6th Coronavirus Global Response Coordination Call convened by Core Group under the leadership of its Executive Director, Lisa Hilmi, and her wonderful team supporting this effort. Core Group is a member organization that has global membership across the international development ecosystem and has been involved in a lot of coordination efforts of not only this type of response, but also in terms of international development work supporting member countries. These types of convenings are very important for coordinating emergency responses of this nature. Their educational value and the opportunities for sharing knowledge, experiences, and coordination collaboration cannot be underestimated. So a big thank you to Core Group, to Lisa, to the board, and to her team supporting these calls. My name is Magnus Conteh, and I'm the Executive Director of the Community Health Academy at Last Mile Health, and a member of the board of Core Group. I am also a member of the Global Digital Health Forum and a founding member of the African Alliance of Digital Health Networks. It is my pleasure and honor to be moderating today's call, but also particularly saddened, I have to say, to be doing so under the circumstances of a pandemic such as COVID-19. In March of 2014, the Ebola outbreak started to engulf the West Africa region and rapidly spread across the Mano River Union countries, which involve Guinea, Liberia, and Sierra Leone, my country of origin. These countries became the most affected countries in the region during that outbreak. In November that year, I was deployed by my previous organization as health advisor to Sierra Leone to support the Ebola response. During my time over there in Sierra Leone, I witnessed firsthand the devastation caused by the lack of coordination, inadequate mechanism for communication, and inaccurate messaging, poor contact tracing, surveillance, and a weak supply chain management system. However, as the outbreak evolved, I also witnessed firsthand the considerable difference made in slowing down the outbreak through the Herculean efforts that were made by local and national governments, NGO partners, UN agencies, the private sector, and technology developers. When better coordination mechanisms were put in place and supported by the deployment of digital tools and technologies, and the resultant impact in bringing the outbreak under control. The deployment of digital technologies supported the following: the use of mobile phones to make simple calls via satellite technology across national, regional, and digital or district level coordinating bodies for the use of digital technology to support the response. We sometimes take for granted connectivity here in the West. But when you go to some of these developing countries and low and medium income countries, the further away you move from the cities, the more difficult connectivity becomes. These digital tools were also deployed for disease surveillance and reporting, for referral and counter-referral, for contact tracing, for supply chain management, for data collection, aggregation, analysis, and visualization. All of which significantly contributed to bending the curve and getting down to zero. I subsequently led my organization's involvement in one of the Ebola vaccine trials in Sierra Leone, where we deployed biometric technology for identification, including fingerprint and iris scan technology for registration and for trial participants and the use of mobile phone technology in terms of sending automated reminder messages for clinic appointments. Today, in 2020, we are in the clutches of a pandemic, COVID-19 outbreak. Today's call is a global response coordination call, and this will focus on digital technologies and their current use in the COVID-19 response. So here is the question. What contribution can the use of digital technologies make in controlling this outbreak and getting to zero? To answer this question, we have a panel of experts and organizations that will present their technology solutions, platforms, and applications, and share with us how they are being deployed for the COVID-19 response. We have a total of, I believe, 6 presenters and organizations, and we have divided them into 2 groups to ensure that we pause after the first 3 presentations for about 10 or 15 minutes to allow some questions from my end and to interrogate what they have presented. These presenters will have 5 minutes each, and as Lisa has already mentioned, she will ring a bell to notify you that your time is up or you only have a minute to go, and we hope that you will help us to manage your time. At the end of each group presentation, we will have this pause that I just mentioned of about 15 minutes for Q&A, and during this time, I will pose the questions to the panel of presenters. Some of these questions will be selected also from the chat room that participants on the call are posing to seek clarification or some answers from our presenters. So please post your questions and comments as the presenters are making their presentations. At the end of all the presentations and the Q&A sessions that will follow, a final 20 minutes of today's call will be allocated to general discussion, during which I will invite some of you on this call to comment on what you have heard from the presenters and or pose questions to them. I ask you all to mute your mics unless you are speaking on the call, and please continue to introduce yourself in the chat room and ask questions and make comments. Assuming that all these instructions are clear, let's get started. First up is Tanya Akon from UNICEF, and she will be presenting Internet of Good Things, RCCE, digital engagement, and more. Tanya, over to you.
Thank you so much, Magnus. And I think as you eloquently explained, I think more than any time before in history, we are all in this together. And certainly that is what we have experienced in terms of using our digital platforms, is that success and effectiveness is only as far as we can work together with others. So the work that I'm going to be sharing with you will focus on one particular platform, UReport. We have another one called the Internet of Good Things, and I invite you all to use the question session to ask me more about that. But given the 5 minutes, we thought a more meaningful deep dive into one area would be helpful. So who is in this together? Externally, as was mentioned by Lisa in the beginning, we can do nothing without our government, private sector, civil society, and ordinary community members. And that's really what holds this whole risk communication and community engagement piece together. It is also the key coordination and spirit of being together that these particular tools that I'm about to share is brought together IFRC, the WHO, as well as my own organization, UNICEF, where I'm the Senior Advisor on Innovation at Scale. The work I'm sharing with you today is on behalf of a large multidisciplinary group across the organization. And you can see highlighted on the slide that this goes from effectively how to communicate things in simple, accessible language through to our communications for development, our IT colleagues, and of course, at the very center, those with programmatic expertise. And coordination in this emergency, as in all others, is incredibly important. And so I think one learning for us has been that with so much that is possible to spin up so quickly, it's really been vital to have a digital platforms working group to coordinate across the multiple solutions that can be scaled out to provide a coordinated response and support to our country offices. Because in the two that you see here, the COVID-19 information chatbot and in the Internet of Good Things platform, we're covering more than 70 countries. Just in, for example, the Internet of Good Things, which is a data-free or cost-free resource. It reaches across 65 countries. To date, there's been 32 million users. And of course, in recent weeks, we've focused on providing information for frontline workers, which has increased their access to clinical guidelines, job aids, and training tools. We've increased information around the prevention and identification of symptoms, as well as things like positive parenting strategies for parents and caregivers, as well as reaching out to youth and adolescents. So that is just on one platform, the Internet of Good Things. I'll focus on the next few slides on our COVID-19 information chatbot. This is the piece that is done with, again, doing this together with a number of private sector partners that open up huge channels for communication. So from a simple feature phone, which is not a smartphone, we can reach out to millions on SMS platforms through relationships with mobile network operators. We are also leveraging as fully as possible the range of social media and digital messaging channels. So these are things like Viber, Facebook, WhatsApp, etc. What has been really critical for effectively communicating to now well more than 2 million people in 42 countries is around having trusted, validated content that has been crafted for digital messaging. And I think, as Magnus was mentioning, we can at least go forth and leverage the experience and expertise we've learned from previous situations like Ebola, where we know that it's not enough to put our kind of expert language out to people, that it needs to be highly accessible, and of course needs to be localized to various country contexts. On the right, you can see an example of the main menu that someone using WhatsApp, for example, would reach through to. And what we are using the information chatbot to do is, of course, provide accurate information to people, and that's one of the things they can access. It's also around tackling misinformation and, in partnership with governments, being able to track and combat fake news and rumor spreading. So there is a rumor reporting functionality. Of course, the data from this, which is in near real time, allows us to refine our programming and our approaches. And we also invite people to ask other questions, because of course this is moving and living, and what digital platforms enable us to do is respond and refine in real time as well. What we're doing next, as you can see, we launched a couple of weeks ago, and there are more than 2 million users. We have leveraged our U-Report country country footprint, where we are in 65 countries with more than 10 million people, mostly young people on this platform, is now to take this proven content and mechanisms to all the other countries that we work in, and make this really easily accessible and easy to launch. So you can try it yourself, and hopefully when you look at accessing this session and the slides, you will choose your platform of choice. Simply send this message to any one of those numbers or those channels, and you'll be able to navigate your way through the COVID-19 information bot. Thank you. I think I've hit my 6 minutes back, right on time. Back to you, Magnus.
Thank you, Tanya. That's a great time management there. And you've set a very high bar for the rest of the presenters. I hope they will follow your example. During your presentation, you referenced the importance of all of us being in this together. This is a global pandemic, which impacts each and every one of us. It's making no distinction. But also how we respond to this should be responding to it together. And of course, leveraging previous experience that you mentioned of how the response, for example, during the Ebola crisis was problematic because it wasn't coordinated. The messages that were sent out initially, in fact, were not accurate in some instances. In other instances, they were not trusted messages, or where they were trusted messages, they were not properly contextualized or localized to be adapted to the cultural context in which those messages were delivered. And importantly, of course, the need to tackle misinformation and rumors that can create so much more problems during a response like this. So thank you very much indeed for sharing that experience and expertise, and for leveraging popular social media to help to inform and add to managing the response process.
And
so
Magnus,
next up is Stephen Meyer from Viamo, and he will be presenting on mobile-based preparedness, digital strategy advice, behavior change communication, data collection, and feedback mechanisms. Stephen?
Okay. And Stephen, 1 second, please. Sorry. Tanya, can you please write, we're having a lot of requests to write the link in the chat box that you were talking about. Thank you. And to let everyone know that thanks to the great Avani Dugaraju at Core Group, all of these, this presentation and the discussion from this presentation today, as well as the previous, are up at the Core Group website. So you will be able to watch again and get those information. Thank you. Over to you, Stephen.
Okay. Hello, everyone. I'll try to end right on 6 minutes, just like the previous presenter. I work for Viamo. I'm the Director of Strategic Partnerships there, and we are working with many organizations in response to the coronavirus. So what is the goal that we're trying to achieve? We're trying to quickly communicate actionable COVID-19 response information, including prevention, diagnosis, and treatment at scale. What constraints are we trying to overcome? Rapid implementation, low or no literacy and language diversity, poor digital literacy, cost effectiveness, rapidly adaptable, combating misinformation, and of course, social distancing. Where do we work? Mainly, we have 25 country offices across Africa and Asia. We can reach almost any mobile phone in the world. I'll let people just quickly look at this to see what countries are on there. What kind of partners do we work with? We work with large international organizations like UNICEF and the World Bank. We work with Ministries of Health and international NGOs. So Viamo uses 3 core modules in our response to the coronavirus. The first is a service called 321. 321 provides on-demand livelihood information for free in 16 of the countries we work in, indicated by this map. People simply dial 321 for free from their simple mobile phone to access an audio menu that says, "Welcome to 321. This call is absolutely free. For information on health, press 1. For information on agriculture, press 2. And so we've gone ahead and uploaded basic coronavirus information to all of our country platforms, but we're still looking for partners to help add more information to this, such as live symptom tracking, self-diagnostics quizzes, misinformation tracking, that kind of thing. The next core module that we have for coronavirus is remote community health worker training. Again, this is delivered via simple phone. It can be delivered via voice or SMS, and we can either push it out or have our users call in when it's convenient for them. We recently completed a community health worker training in Rwanda, where we trained 60,000 community health workers on PTSD and mental health in the lead up to the 25th anniversary of the genocide, where they noticed a spike in mental health cases. This is a quite low cost per trained worker, oftentimes around $3 or $4 for a trained community health worker, can be implemented rapidly, and can have surveys integrated into the program or into the content to measure baseline and midline knowledge. The third module we have is surveys. Again, these are delivered via simple mobile phone. They can be either delivered using interactive voice recording, so pre-recorded audio messages that are delivered to people's simple flip phone, or via SMS for populations with higher literacy. Again, they can be rapidly implemented, have a very low cost per response, and are accessible to populations with no or low literacy. No requirements to put staff in the field to potentially spread coronavirus more than it already is. For coronavirus, we're doing healthcare access monitoring, so asking the general population, whether they think they'll get access to healthcare if they go to the hospital, to monitor, when a country's healthcare system is reaching its capacity. And of course, also knowledge surveys to see if people's understanding of hygiene and social distancing is improving. Some of the other tools that we're exploring for coronavirus are SMS and interactive voice recording based contact tracing, chatbots on WhatsApp, Facebook, SMS, and more. We can set up call centers and hotlines, and also do general targeted mass messaging. Oftentimes we partner with local governments to message, millions of people in their country within a day. How do we implement our communication programs? First, our partner comes to us with a binder full of content. We help them translate that into audio content through a workshop. We then translate and record the content, Viamo does, and field test it. The mass communication campaign goes live, and then our partner can see all of the results, like who's listening to the message in what language, from what location, what gender, what age, in real time, through some pie charts and bar graphs. So please get in touch with me. I'll leave my contact information in the chat too. Hey, look at that. All right, thanks everyone.
Great. Thank you, Stephen. That was a great presentation as well. And I like the way your organization actually looks at identifying what the constraints are, what the challenges or the pain points, as we usually call this within this space, or what the use cases are, and then you develop the technology to address that. So the principles of digital development, bear in mind the user and designing your technology to address their needs, as opposed to trying to retrofit the use of the technology. You also referenced the importance of remote training of community health workers. And I want to say, particularly in this current context of an outbreak of this nature, such a highly infectious outbreak, social distancing is very important, and it's been enforced in a number of countries. So reaching remote community health workers and other frontline health workers via your training platform will be very critical at this particular point in time. You also mentioned low-cost implementation, very important, where Ministries of Health have to pick up the tabs afterwards, addressing low literacy, and of course, field testing your platform before deployment, and making sure that you have sufficient analytics behind that to feed back to the ministry or to implementing partners in terms of how the platform is being used and who's using it. So thank you very much for that presentation. And I would now like to call upon Gerald Thomas from the Ministry of Health in Sierra Leone, my home country, to share current initiatives and lessons learned from the Ebola outbreak in West Africa. Gerald?
Yes, thank you very much, Magnus. This is not my presentation. Probably the need. Okay, thank you. Thank you very much, and thanks to the call group for giving me the opportunity to present within the call. Hi, everyone. My name is Gerald Thomas, as already been stated. I'm the ICT manager for the Ministry of Health. I was here during the Ebola period, and currently I was moved to another ministry, and now I'm reinstated back to the Ministry of Health. And my presentation today is about Sierra Leone experience with reference to Ebola and responding to COVID-19 using digital technology. So basically, during the Ebola crisis in Sierra Leone, one of the challenges that we have was the fact that we were using the traditional means of communicating to people. And unfortunately, we were using the radio stations, handbills, billboards, small community meetings, and PA systems, which is a public address system, to communicate to them. So what we found out that, and the ICT was not actually involved directly at that time. So what we did when we were called was to do the following things. We actually created WhatsApp, short messages, videos for dissemination to the people of the public, do a Facebook page, do a mass text messaging broadcast, and we do IVR for messaging as well. And we did a website which was updated on a day-to-day basis during the Ebola period. So during our challenges with the Ebola period was that the first fact that most of the information were moving helter-skelter, and most of them caused panics which were due to mistrust. People don't trust the health system. People don't trust the information which was coming from the Ministry of Health. There was also misinformation, which was due to disinformation and misinformation from political reasons and all the rest of it. Also, there were questions about, at the end of the Ebola period, there were questions about the ownership of the Ebola data, which we don't have currently, and this is due to the initial position which the government was during the Ebola, not having their own capacity in-house to handle their own data. And later, the involvement of some critical players, right, in the system for ICT was also causing a lot of issues like Eld Africa. Now, what we have done differently to the COVID-19 was, in this time of the year, we actually planned it before, wherein a tracker system was developed by the Oslo, and those modules were then deployed directly to our server locally, and we have them on the cloud as well. We also have a surveillance system which was created, and this time around we're using a rapid poll from the UNICEF, which was used to capture information from the public, from the stations, using SMS means, and which makes it easier and faster to get the information. We also have a website wherein we use the chatbot, and the chatbot is being plugged into the WhatsApp, and then we have information directly from the public, and we disseminate information directly to the public, which makes it easier. And finally, we use the government information system, which actually helps us to have a the call center, or the messages from the call center is being directed to the DMOs in the district. So that makes it easier for us to disseminate information. Now, the next step for this is that we are planning on going to more proactive messaging systems to beat citizen journalism, because that's the phone of the day. Everybody wants to be the journalist in Sierra Leone. So we want to have a system which can beat them at real time in order to dispel disinformation and gain community trust. We want to own our own data. This time around, we don't want to lose our data as we have already done for the Ebola, so we want to have our own data and get proper ownership of it. Community structure, we want to create, improve on better performance of the community applications, like the one which was by previous speaker have spoken about, to actually help inform the CHWs with reference to the current COVID system in Sierra Leone. We want to also have a partnership coordination, which is, everybody have already spoken about it, which is act earlier, act together as government and as private partnership to develop, to protect our people. And also going forward, we want to now have like an innovative hub wherein we will have technologies coming up. It's not only when we have challenges that we provide technology. We should have technology prior to epidemic or pandemic. And I think that's all for me. Thank you. Magnus?
Great. Thank you, Gerald, for a great presentation, brief and to the point, and you've kept to the time as well. So thank you. So during the presentation, of course, you took us back to the Ebola experience that you had in Sierra Leone and some of the challenges that emerged from the primary use at the time of traditional methods of communication. And of course, then the resultant difficulties and challenges with regards to misinformation and lack of data ownership and that lack of coordination, how it contributed to some of the challenges. And what you've done in your presentation also is to say to us how those lessons that were learned from the Ebola crisis have not been used or are now currently being used by your ministry to put structures and systems in place that will ensure that there's better coordination, that you're using the DHIS tool module to coordinate some of the activities, including disease surveillance, and also having your own website where you can provide trusted information as a way of countering the misinformation that's around. And of course, data ownership being very important. If we have all these different technological solutions being deployed and they're not interacting with the Ministry of Health, or they're not interoperable, and therefore the ministry is not able to pull that information together to collate it and analyze it and aggregate it, decision-making will be problematic. So thank you for highlighting those particular points of coordination and systems being put in place. At this juncture, I think I would like to take a pause. Lisa, if that is okay with you, so that I can pose some of the questions that are coming through the chat box, but also some points of clarification that I'd like to pose to our presenters so far. Is that okay?
Absolutely. Lisa? I've been sending you the questions in your chat box, so you'll see them.
Great. Fantastic. So my first question is around the importance of government leadership. And I would just like to pose the question whether, in fact, our three presenters, or our first two presenters, particularly UNICEF, your role within countries as a UN agency, to what extent do you see government leadership in terms of crisis like this, or even before this type of crisis? How important is it to have that government leadership and coordination?
Thank you. That's an excellent question. And of course, for an organization like UNICEF, who is present in a country per the agreement with government, that leadership is absolutely critical. I think with this particular response, we can see an incredible array of different approaches that governments have taken and different leadership styles. And those have resulted in very different types of responses. But I think the key piece is not only leadership when something is happening, but what Magnus, you alluded to, which is around the emergency preparedness. It's really taking us back to that whole idea, particularly in the world of development, that there is no, it's just really a continuum between development and emergencies and back again to development. So critical are the kinds of leadership perspectives and planning, as well as just the day-to-day capabilities of government, which are tested in these kinds of circumstances. And it is these kinds of circumstances that will lay out and exploit every single weakness. So if that weakness is logistical, if it is, as others have mentioned, a mistrust of government and a mistrust of information, any weakness that exists prior to this is only going to be completely amplified. So leadership and of government, key for us and key for citizens, but we've also seen very interesting and impactful examples of leadership at all levels of government, but also among the private sector and amongst the civil society. So I think it also, again, reinforces all those key actors in every society. Over.
Thank you, Tanya, for sharing that perspective. And I would just like to ask Stephen as well, in terms of the work that you do, considering the importance of managing this misinformation that happens during this type of crisis. Do you have any data, or do you have any sense of what sort of data is there of the extent to which miscommunication is experienced by various countries? Do you have any reference point, or do you have any indication of the extent of that?
Yes, we understand that there are a lot of organizations tracking myths on social media, but that there are also a lot of myths that go around in communities that don't have access to a smartphone or social media. We haven't not deployed it yet, but are working to find partners to help us include myth tracking and myth busting on 321. So through 321, where we're getting almost 1 million calls per day now, we would like to start asking the question, how do you think coronavirus is transmitted? How do you think you can prevent it? Collecting and analyzing all of that, and then, on 321, then busting those myths for our audiences. So if there are any partners out there who would like to help us add that to the 321 service, please reach out to me.
I like that. We are in this together. So the more partnerships we have, the better it is bringing our collective expertise together. But Stephen, I'm not letting you go yet. I have a technology question here I'd like to ask you that has been posed in the chat box. What is the difference between the chatbot being mentioned here and that of WHO?
Yeah.
And where is the possibility of young people or younger audiences who do not have time to watch the news? How can we use things, social media like Instagram, for example, that is very popular with girls?
Mm-hmm.
How can we best integrate that to this type of messaging platforms?
Yes. So Viamo has implemented chatbots for many smaller scale health projects in the past. I need to continue my conversations with UNICEF, and I think that probably for the COVID response, it's probably best if we refer people to UNICEF's chatbot. We don't need to reinvent the wheel and have parallel programs going on.
Great. And one last question for you is about you mentioned the interactive voice response.
Yes.
Was that used primarily to disseminate information, or was it sort of an opportunity to have an interactive Q&A with the general public?
Yeah. So I'll clarify exactly what IVR or interactive voice response is in case people aren't familiar, but it's you listen to pre-recorded audio messages in your local language, and you can interact with it by pressing keys on a keypad, so it does not recognize your speech. It can be used either in a push or pull format, so our users can call 321 to access this interactive voice recording menu for free. They don't pay for airtime. The mobile network operator covers the airtime. Or we can also do push interactive voice recording. So for example, when we're training community health workers, we'll send out an interactive voice recording message that our community health workers can interact with using their keypad.
One final question for you before I let you go,
Sure.
Stephen. There's a question here about whether you are working with internally displaced communities, such as in camp settings or for refugees. And if yes, how is it working in terms of your deployment?
Mm-hmm. So I don't think we have yet worked with internally displaced people or refugees for coronavirus, but we have extensively before that. And how does it work? We would have to gather the phone numbers for everyone in the camp, and then we can send messages to them based on the phone numbers list that we have.
Thank you, Stephen. You've been a gentleman to put up with all my questions. So next, then, I would like to ask Gerald a question about coordination. And you mentioned the experience during the Ebola crisis and the lack of coordination and the deployment of various tools and technology solutions in the country. without proper coordination. Could you just highlight for our audience what action the Ministry of Health and the Ministry of Information took following that experience to put in place a better coordination mechanism in terms of the deployment of technology solutions?
Okay. Before, I think, well, everybody in terms of every pandemic or epidemic is looking for the opportunity and want to showcase what they have. What the Ministry of DPPI does, or as the ministry, part of the ministry is DPPI, which deals with information. So what they did was that we established a condition wherein we say that these are the tools that Ministry of Health want to use, and we specified those tools with them. As a way forward, we also established what is called the Eld Hub, wherein people before this COVID-19 would showcase what they have, implement applications which they have been using, showcase them within the hub so that the hub will be aware about it, and other organizations who want to do something would now liaise with them rather than creating a new platform as well. And the other thing that is being done, is the fact that they establish what is the AOC. There is a group which leads the AOC, and that based on the conditions of the group, it's clearly specified based on pillars, and one of the pillars is the ICT, and that pillar of the ICT will now give recommendation on what is to be done rather than all donors or organizations imposing what they want to do for the ministry.
Thank you so much, Gerald, for sharing that experience. And it's good to hear that the ministry took the lessons learned from the Ebola outbreak and are now deploying those to have better coordination and better use of resources in terms of technology deployment. In the interest of time, I would like us to move on to the next set of presentations. But of course, after that, we will also have another opportunity for Q&A, just as we have concluded for this first round. So next up is another colleague and friend of mine, Caroline Imbinio of AMFREF, and she will be presenting on the LEAP mHealth platform for training healthcare workers. Caroline, over to you.
Thank you, Magnus, and hello. My name is Caroline, as introduced, and I work with AMFREF Enterprises, which is the social ventures arm within AMFREF Health Africa. I'm calling you from Nairobi, Kenya. My presentation is about the LEAP mobile learning platform, which turns 8 years old this year. And LEAP is a product of quite a unique partnership between the Ministry of Health in Kenya, AMFREF, Accenture, Safaricom, and Vodacom. We were looking at 8 years ago when we started working on it, we were looking to develop a solution that really addresses the unique needs of Africa. So with Africa as a mobile-first continent, we knew that if we want to reach community health workers with standardized content where they are, we knew that mobile was the way to go. And we knew that although community health workers, most community health workers have a mobile device, most of these devices were basic phones. So we knew we needed to build a solution that can be used by any mobile device, allowing us to reach learners on a basic phone or a smartphone using text and audio and multiple languages. We wanted to build a solution that does not require internet connectivity at all. So this is what LEAP is. It supports learning by community health workers where they are using the device that they have, using text, using audio, and in multiple languages. So LEAP currently has Ministry of Health accredited content that is deployed to community health workers. It also has customized content that other implementing partners who are looking to reach community health workers can deploy using the platform to provide either complementary or supplementary training to the community health workers. It allows us to measure learning process, so through evaluations, quizzes, practical exercises, as well as real-time performance reports, both to the community health worker and to their supervisor. It's gamified, so it has leaderboards, and community health workers can see who is performing better than others within their community units in specific topics. Learners can interact with each other, so peer learning through closed user groups similar to WhatsApp, and they can communicate anytime, anywhere at a touch of a button with their peers and also with their supervisors. This is not the first time LEAP is being used in infectious disease response. It has previously been used with Ebola, with Lassa fever, with cholera. So
Caroline,
in response to COVID,
sorry, can you make sure you advance your slides, please? It's still on the first slide. Thanks.
So this is what I was talking about. Thank you, Lisa. So this is what LEAP does. It allows us to send messages in text, in audio, in multiple languages. It has quizzes and assessments. It allows learners to chat with each other in a closed group and with their supervisors as well, to ask questions, to provide feedback, and especially feedback from the households that they are visiting, and to get clarification and provide reports to their supervisor. So in Kenya, in response to COVID-19, the Ministry of Health, together with other community health stakeholders, developed key messages for the community health workers in English and in Kiswahili. This in audio and text as well, and it included quizzes. So AMFREF has so far, in the past 3 weeks or so, deployed these messages to over 50,000 community health workers who have reached over 1.5 million households and over 8 million people. We are also administering a knowledge, attitude, and perception study, and the feedback of that is being used to inform new information to the community health workers. So I'm going to show you a mini demo of how the platform works in English, and so that it's easy to understand. So you will get an introductory SMS such as this one, and I'll quickly go through the demo. So you get the key messages, and then you can listen to an audio. And the audio isn't working. So I'll try and play it from my laptop, and I hope you can hear it.
Hello, dear learner, and welcome to this session. My name is Mr. Bakari, the Public Health Officer. In this session, you will learn about COVID-19 and its signs and symptoms. Dear learner, have you heard about COVID-19? Thank you for your answer. COVID-19 is a new respiratory infection of coronavirus that started in China and is spreading across the world. It is found in animals and is spread to humans. Dear learner, do you know some of the ways that coronavirus can be spread? Thank you for your answer. There are several ways that coronavirus can be spread.
So I'll just stop it there. So that is a quick sample of how the content is divided into mini topics, which has structured SMSs that come through. The community health workers read through the SMS, they get audio, and then they move into the next set of SMSs. We have a pre-test that goes with this, as well as a post-test at the end of each topic, and we are able to track the performance of each of the community health workers through each of the topics that we provide them. This is a sample of some of the chats that we picked directly from the chats that the community health workers have amongst themselves and with their supervisors. and they ask questions, they share the feedback that they're receiving, they encourage each other to perform better. The guys on the leaderboard normally get a cheer, well done so-and-so for, performing best in this topic. And lastly, I will share one of the things that we are encouraging community health workers to do, practical exercises, setting up, hand washing stations in their communities. And this here is a community health worker from Makueni in Kenya called Festus, who set up this hands-free washing station for his community. So the supervisors send back to us the evidence of practical exercise done by the community health workers that they supervise. So essentially, this is what we are doing in Kenya in response to COVID. That's it. The end of my presentation. You can see a link to the LEAP mobile website where you can find additional information. Thank you.
Bang on time. Thank you, Caroline, for an exciting presentation and the demo of your LEAP platform, which I'm familiar with, considering the area of focus that we are working around as well. And particularly, I like the fact that you have designed this platform to address the unique nature of the continent, considering the challenges of connectivity, the challenges of remoteness of some of the communities, and use of the text messaging, the audio messages that you just demonstrated, and of course the multiple languages, considering the fact that most community health workers, at best, they are semi-literate, but in most countries, the percentage of non-literate community health workers is very high, and therefore it's important that we're able to address that by providing language translation of the training materials. Importantly, also, you mentioned the accreditation, the use of accredited materials from the Ministry of Health. We should never forget that, because that is developed within the context of the disease burden of their country, but also in the context of the policy that determines the scope of work of the community health workers. So it's always important that we get our content accredited or vetted by the ministry before we push it out. And of course, you have used the various forms of gamification, peer learning, and importantly, the use of CUG, this closed user group, which allows for communication across community health worker programs, and also that they are able to communicate with their supervisors while they are in remote communities or remote locations when they are doing their work and getting support. So thank you very much for highlighting those very important elements of designing this type of training platforms for community health workers. Next up, Elena Val, International Organization for Migration, and presenting on IOM e-PHR platform that assists member states and related stakeholders in performing adequate health assessments for migrants, which are fostering access and continuity of care. Elena, over to you.
Good morning or good afternoon or good evening to everybody. Thank you indeed once more for having me here. I work for the regional office of IOM in Brussels, hence the presentation we are providing. It's presenting an ICT tool of IOM that has been developed within the European Union in collaboration with the European Commission and member states that have been experiencing migratory pressure during the so-called crisis during 2016. The tool has been generated further to consultation with the European Union, the European Center for Disease Control, and member states, specifically the Health Security Committee. And it's based on a personal record that was initially paper-based and on handbook for health professionals to perform health assessment for migrants. IOM, I want to make a point, does not represent only documented migrants, but all the migrants, so asylum seekers, undocumented migrants, and so on. This tool was generated based on research at field level that evidenced that there was a gap in transfer of medical data from point of entry across countries and within the same country due to the lack of often exchange of records within member states, and then at national level, often NGOs performing health assessment initially and then passing the case further to the national systems, hence lacking some data and so on. And IOM stepped in to collaborate with its member states in the region to help developing a platform that was indeed able to fill this gap. And here you have a brief summary. The data are cloud-based, but they can be server-based. You have a record that is comprehensive, so can be used for COVID, but also for non-communicable diseases, and it's intended indeed to address urgent matter or long-term matter, depending on the setup under which doctors are operating. It's built on the expertise of IOM in data management and data sharing through our health assessment programs that exist across the planet within movement as resettlement, and has been then adapted to the situation within the European Union. So we've been able to comply with national requirements to transmit information from point of entry, from camps to hospitals and so on. And then indeed to allow different health professionals, only health professionals, so doctor, nurses that are authorized to enter the data, to then access and retrieve previous health assessment and complete the history of the migrant. Practical example, if you as a doctor yesterday introduced a vaccination and met a patient, me today re-encountering the migrant another time in another location, if the migrant is on the move or has been moved, I can see what has been done and further update, and on and on. At the moment, the file is not available for access to the migrant, but it's in the cards. And then another important point is that the data can be analyzed, and this is, apologies, I'm going the other side. And this is also very key here, just to stress again that all has been done in line with the GDPR, so the data protection regulation of the European Union, and following the UN data protection rules, which are also the IOM one. And here a brief overview of the countries that join the action. And we are proud to say that in Italy, the project already scaled up to sustainability. In Sicily, the tool is becoming the regional tool for health assessment for migrants, connecting hospitals, camps, facilities, and reception centers. And when I was mentioning about data and aggregate data and reporting, this is very important because we have a back-end tool that is able to provide aggregate data and analyze the medical trends. This can be adapted, of course, to COVID. What we have here is, for instance, an example. You can see the countries of origins, the routes that those migrants, the travel and the transit that took place as reported, the main medical conditions that those population is experiencing, and then with this, it's an important tool also for policy and advocacy purpose, especially for us to then coordinate and further discuss how to better handle migrants. Migrants, of course, are very vulnerable during the COVID pandemic. I don't need to stress it, but I will do it again because of their lower capacity to access health system integration in many countries. Universal health coverage is not present all over the European Union, and the rights to access to care are different across the planet. The tool can be interfaced, has been already interfaced with national or other platforms, and can be also adapted ad hoc based on the national needs, as was the case of Italy that I just mentioned. One other point that I wanted to make is that the tool is also available in the Sustainable Development Goals website as one of the best practices, and has been awarded as such through a competitive selection of which we are proud. Over to you. Thank you.
Thank you, Elena, and congratulations on that award. And thank you also for the fantastic work that you guys are doing supporting migrant communities. A lot of these migrants do not leave their homes voluntarily. A lot of them would prefer to stay where they are and be with their communities and their society and their families than migrate to other countries. And being able to provide this type of services to map the migrations, to map their needs from a health perspective, and aggregating that data for decision making in terms of advocacy and service provision is really impressive. And of course, you mentioned during your presentation the data gap that exists, and how, in fact, using a tool like this to track migration and to track this information and data across borders and consolidating it through the systems that you described is another very important use of digital technology. And particularly with this type of outbreak, the COVID outbreak, migrant communities or populations are very vulnerable. And therefore, whatever we can do by leveraging digital technology to provide these type of services for decision making and policy development and for advocacy is also very important. There is one point you mentioned which I would like to flag later when we come to Q&A, which is the issue of regulation and interoperability, particularly when it comes to the EU and the importance of adhering to those type of international and national regulatory frameworks. So thank you for an excellent presentation.
Thank you.
Great. Up next is Liz Colway of Sabin, and she will be presenting on Sabin Boost Community's work around the empowering of immunization professionals and providing them with opportunities to connect, learn, and lead. So over to you, Liz.
Great, thanks so much, and also thank you to Lisa and the rest of the group for including us in the call. So my name is Liz Colway, and I'm Manager of Community Building and Digital Engagement at the Saving Vaccine Institute. We're a global health nonprofit organization based out of Washington, D.C. That strives towards making vaccines more accessible, enabling innovation in the field, and expanding immunization across the globe. I'm also joined on the call today by my colleague Jen Peter, who's Director of Community. So in my role, I support a new initiative of Saving called the Boost Community. Boost, which is formerly known as the International Association of Immunization Managers, launched in January this year and is a revitalized in-person and online network of immunization professionals from around the world. Boost was developed in close ongoing collaboration with immunization partners, experts, and professionals to respond specifically to isolation, burnout, and fatigue in complex environments that immunization professionals often face.
And Liz,
yes.
Liz, your sound is a little bit cloudy. Can you get closer to the microphone, please? Thank you.
Yes, so sorry about that.
Thank you.
Can you be a little bit better now?
Absolutely, yes. Thank you.
Okay, apologies again. So speaking of complex environments, we appreciate now more than ever that there are questions about whether to continue routine immunization services and how and if you can do that safely, and then also potentially how to prepare for the rollout of a COVID vaccine. So we're seeing opportunities arise from the Ministry of Health and EPI staff, including Gavi's offer to countries to respend 10% of their health system strengthening funds on COVID response, which is a great offer, but also a complicated one. And that's really where Boost comes in. The mission of Boost is to foster a global community that enables immunization professionals to connect with peers and experts, learn skills that build capacity, and advance careers and lead immunization programs in challenging contexts. In addition to our in-person workshops and activities, we built an online platform, boostcommunity.org, that connects the community and offers learning opportunities, which can be accessed from anywhere and at any time. So all immunization professionals are welcome to create a free account on our site to gain access to our community and resources. The online platform, which was originally designed for college alumni groups, excels at connecting individuals with one another. We have an interactive member directory as displayed, along with a community feed, which looks similar to a Facebook feed. So members can create profiles to display their expertise and can locate others in their community or work sector. We also have a private messaging feature, which allows for a direct connection. So in response to the current crisis, we've been sharing out COVID-19 resources in the community feed on a regular basis. And we've also been encouraging our members to post relevant resources, comments, and questions. For example, the World Health Organization recently released guiding principles for immunization activities during the COVID-19 pandemic, and we disseminated this resource widely on our platform. We also have a variety of other resources, including learning groups organized by different topics and trainings, and a live events calendar. Our courses hone in on leadership and advocacy skills, which are, of course, of particular importance during the coronavirus pandemic. In fact, we're launching a 6-week course at the end of next month with the Geneva Learning Foundation on adaptive leadership, and in other words, how immunization professionals can lead in the midst of a crisis. Moreover, we've been collaborating with a number of our partners to highlight relevant COVID-19 updates through these different website features. For example, we're in discussions with the World Health Organization, Gavi, and other partners to co-host webinars focusing on answering immunization professionals' questions and finding opportunities to share and support these workers with more tailored support on leadership and advocacy. So we're working to understand what immunization professionals need right now, and we'll continue to take the pulse of our community throughout the crisis to ensure that we're responding to the needs of our members as best we can. Currently, we have a growing network of over 400 Boost members from more than 85 countries working in a variety of positions and sectors within the immunization field. The last thing I'll say is if you are working in the field of immunization, we'd love to partner with you to share out your resources, webinars, and other news with the Boost community. Thanks again for your time, and we're happy to answer any questions.
Great, Liz. Thank you so much for another great presentation and for keeping to the time as well as we come to towards the end of this this particular call, focusing on digital technology and its use within this particular outbreak. So with that, I will turn to Q&A. And first up, I would like to turn to you, Elena. You mentioned during your presentation the need for adapting your technology and the work that you are doing to the EU regulatory framework and ensuring that there is compliance to GDPR. How important is that for technology solution developers when they're developing these solutions for deployment in countries or in supporting outbreaks, for them to comply with regulatory frameworks of that nature, either at the EU level, this type of regional organizations, or at national level?
Yes, thank you for your question. Based on our experience, it's and not only on our, it's key because indeed the GDPR has a reputation to be the most advanced legislation on data protection in the world at the moment. I will personally not enter in this area, but I think whatever legislation and regulations are in place within the environment we work as ICT experts need to be respected and followed, or at least given our nature and our rules and regulation as UN, we should work in line with such. And this is important indeed, especially in Europe, where you have a legislation that is actually supportive ICT innovation, but also protecting patient rights and individual rights to enforce such approach. because it will ensure that the tools that are implemented are indeed not harming, and I fully support the approach of better no harm and then to discuss on what to do as action. And so the no harm is the first approach, and in ICT especially, given the vulnerability of the subjects we work with, it's key to be conscious on what solution to use in the respect of the individual and in the respect of the legislation when the legislation is protecting the well-being of the people. It's why as IOM then we are lucky because we are also in an advisory role and we have a different position as a UN organization. Over to you.
Thank you so much for providing that clarification. Caroline, there are a couple of questions in the chat box for you regarding your presentation. The first one relates to the audio functionality of the LEAP platform. And a member of the audience is interested in finding out how interactive, or whether this functionality is interactive in the sense that community health workers are able to also ask questions to get certain answers back to the platform. Is that a functionality that is available on LEAP?
Yes, certainly. The community health workers can send feedback either in text or in audio form. In fact, on the LEAP platform, we have regular town halls where community health workers send questions into their supervisors, and then they have an audio answer from somebody like within the county leadership, administration, or the community health focal persons, who then responds to these questions, and that response is sent in audio to the rest of the community health volunteers. So it's a fairly interactive platform, and it allows communication using the usual community health channels and processes.
Great. And the next question is about, you mentioned the analytics that is built into the phone and the performance management system that is also built in, and the provision of performance report. A member of the audience is interested in who is that information provided for? Is it provided for the community health workers themselves, or is it being provided for their managers?
So the reports are at various levels. The reports, the performance for the quizzes and tests that are done are viewed by the community health worker. They are also viewed by their supervisor. The supervisor sees not just the performance of one community health worker, but all the community health worker that she would be supervising. And then at a sub-national level, at a county level, for example, in Kenya, the county health team also sees performance of all the community health workers across the different topics. They can be able to see how many households have been visited, so reports provided by their supervisors. And then at a national level, they're able to see performance across all counties.
Thank you, Caroline. And Liz, during your presentation on your online platform and this community of practice that you are building, you mentioned the complex environment that currently exists in the outbreak situation, and the pause in terms of, or consideration that's been given for a pause in administering routine immunization, but also preparation for rollout of a potential COVID vaccine. I'm just wondering, where do you see technology beyond a digital platform being utilized in terms of preparation for the rollout of a potential COVID vaccine, hopefully sooner rather than later?
Sure. So, I mean, I can. Oops, sorry, can you hear me?
Yes, please go ahead.
Sure. So you're asking beyond the digital platform. So I can definitely speak to what's been going on our platform. So we've been bringing in experts to kind of share our information. We've also are trying to provide a space where immunization professionals can kind of share out their experiences and kind of figure out how to deal with the routine immunization services going on in the midst of the pandemic. So it's something that we're continuing to keep tabs on. I know in addition to our platform, there's been a number of WhatsApp groups that have been created, usually with immunization professionals within countries. And I know that's been another great way for people to connect and get out information.
And Magnus, hi, this is Jen Fluter, also from Sabin. How are you?
Hi.
I think to your broader question just about how we see technology being integrated into a potential new vaccine rollout. I mean, I think there's a lot of different ways that we'll see that, and I think there's a lot of ICT solutions that will be necessary to do it quickly, efficiently, and safely. I think some of the pieces that we're thinking of up front are what are the protocols going to be? How are we going to share those out, and what does that look like? And a component that we've been thinking a lot about as well on our end is the advocacy component, right?
Right.
Much bigger question here, but really thinking about how do we advocate for the vaccine to be released equitably across countries, not just to the places where maybe they're produced or most well-resourced. And so we think technology could play a big role in also sharing, gaining momentum behind that advocacy and moving that forward. But I think for the rollout of a new vaccine, we see lots of layers of different kind of technologies that will be necessary, from healthcare workers, mobile device type technology to track things, all the way up to how are we going to actually roll out some of these new protocols that WHO and others will share out. So more to come on that, I'm sure.
Right. Thank you, Jen, for that additional intervention. So I just want to go back briefly to something that you have mentioned in terms of how the Ministry of Health have put systems in place to enhance coordination. And he made reference to the DHIS2 platform that the Ministry of Health is using. But of course, I know the Ministry of Health was using that DHIS platform even before the Ebola outbreak. And the DHIS platform is a platform that has been deployed in several countries. Most low to medium income countries use that as a central digital platform for the Ministry of Health to collect data. We have Kuno Sterling from the University of Oslo, the developers of that platform. And I would just like to invite you to make a comment about the importance of a platform like that and the importance of interoperability between these multiple apps and multiple technology solutions that are deployed during this type of response, and the importance of that type of that interoperability with the DHIS system and how that could contribute to coordination and better decision making. Knut?
Yes, thank you very much, Magnus. Can you hear me?
Yes, please go ahead.
Okay, thank you. Yes, I will be very brief since we don't have much time, but we have seen DHIS2 is now operating in around 60 countries and well integrated within the Ministries of Health. And we have thousands of users in some of those countries. So we think it's very, very important to leverage the knowledge of those skilled users all the way down to community health workers in some countries, as well as the backbone of, the master facility list and having a shared repository for all this information. We think that it's wonderful to see all these initiatives that go towards the general public, and DHIS2 is much more focused on the health system as such, but we think bringing this information into a central hub can be of great value for managing this outbreak. So I will mainly point people to the website dhis2.org, where we have videos of what we've been doing for basically setting up for COVID packages that can easily be implemented in existing systems for point of entry, for contract tracing, for line listing, and for general reporting around resources and initiatives around the COVID outbreak. So please just go to that website and you can find more information on what we're doing. With more than 50 Ministries of Health have actually contacted us now for assistance with the outbreak. So it's already operational in maybe 15 of those.
Thank you so much for that intervention. And we're almost up to the time allocated for this call, but if you could just bear with us so that we can round up this call today. Such an important discussion and sharing of knowledge and expertise across the globe. We have over 170 participants on this call. But I want to take the opportunity also to thank our presenters who have presented today and for their contributions. I also want to take a personal sort of a position here in thanking all health workers across the globe who are sacrificing their own personal well-being and safety to support the response. And with that, I also like to mention, in designing these solutions that we are using, the importance of factoring in the gender dimension, the disability dimension, and ensuring that we solve for that. We design with those sort of limitations in mind for the disabled community, but also how these solutions should not further disadvantage women or young girls that we are sort of have a responsibility to support across the work that we are doing. And with that, I would like to hand over to Lisa.
Thank you so much. I'd like to say thanks very much to Avani Dugraju from the core group team, Magnus Conteh, thank you so much for your excellent moderation, as well as to all of our presenters. I think the next 2 weeks are going to be very tough in this pandemic, and this collaboration and coordination on these very important work that all of you are doing is vital. So that is the reason that we are having these calls, and not just at the global level or the US. As you can see, this is broad representation from the country level, from the Ministries of Health, from the frontline health workers, as well as the global voice. So we will be continuing these calls every week. Next week, it will be on gender and all the gender dimensions in COVID. And join us for that conversation. If you're not on the core group listserv already, please go to our website, www.coregroup.org. You will find all of these presentations since the beginning of February, as well as many COVID resources from around the world that we have a vetting process to look at, as well as how to become a core group member. So thank you very much for your work. Stay safe, and I appreciate your time today.
Stay safe, everyone, and goodbye.
Goodbye.